fantastic to have this opportunity to speak to you all today about dementia in the learning disability population. It's something Furqan and I are really passionate about. And Louis and I met briefly at a Dementia Summit. And following that summit, I went back and spoke to our CEO and said, we need to do more. We need to do better. We need to find out more. There's just not enough out there. I don't know how you quite follow Big Ian and Tim. They were both awesome. And yeah, let's get going. So, dementia in the learning disability population. I did smile when Tim said his slides were not death by PowerPoint. We do have quite a few. It's not death by PowerPoint, but we do have quite a few because it's a really big subject. To give you an idea, our original report was 146 pages long, and my claim to fame with Furqan is when our CEO tried to print it, it broke her printer. So this is condensed down quite a lot. So dementia in the learning disability population is really under-resourced, very little known, and the information's quite scattered. So following the Dementia Summit last year, we went away and we had a look at what we could do to understand more and really bring that together and really understand where people were at, what was happening for people with a learning disability, and what could we do about it. So I'm going to sound a little bit like Chris Whitty, but could we have the next slide, please, Furqan? You're going to hear a lot of that. So what we're going to cover in this presentation is the scale of the issue, the prevalence, and why this really matters so much and matters right now. I'm then going to hand over to Furqan, and he's going to go through the risk factors and ageing in place and what we can do about that. He's also going to share some data from our own research, and then you're going to land back with me for the key takeaways and the next steps. So, next slide, please. Did you know people with a learning disability experience dementia at a significantly higher rate and at a younger age than the general population? It really does represent the most serious and persistent health inequalities facing our sector today. It's poorly recognised in mainstream dementia policy and in dementia commissioning. And this is because those elements are really aimed at the general population and over the age of 65. So often what you're finding is frameworks that are standardised and are really work well for the general population aren't fit for purpose within the learning disability population. Next slide, please, Furqan. So our own research. So last year we spent a long time, Furqan and I, really focusing in on what was happening, where was it happening, what was data was out there, what was being recorded, and where the gaps were. So we did a comprehensive review of the current landscape across England and Wales, and that included freedom of information requests submitted to all local authorities. We also conducted our in-house research, and we used insights from the Alzheimer's Society, Alzheimer's Research, Down Syndrome Association, Down syndrome in America, and Alzheimer's across the world, our own NHS, CQC, and sector charities. One charity in particular, Glenmore Trust, who are based in Carlisle and support people with a learning disability in supported living and day services, were absolutely awesome at giving us access to the people they support, sharing case studies, and letting us really help to understand that what they were seeing, we were seeing, and other people were seeing. We've used qualitative and quantitative data from the people we support, their families and staff. And we did have some key focus areas. We looked at the early signs and symptoms, and we looked at the risk factors, the barriers to diagnosing, the housing conditions, and real life case studies, one of which we're sharing with you today, and the family are really passionate about Mark's story getting out there to everybody. Next slide, please, Furqan. So the scale of the issue, who is affected, how common is dementia in the learning disability population, and why is it we need to act right now? Next slide, please. So here's some key statistics for you. Dementia has a 10% higher rate in learning disability population aged 50 to 64 versus the general population. 33% of people with Down syndrome develop dementia in their early 50s. And 90% of individuals with Down syndrome develop Alzheimer's. This makes it the leading cause of death. Now, I personally find those statistics absolutely shocking. I think anecdotally, I knew it was high, didn't know it was that high. And it hurts me when I read those, really hurts me. Next slide, please, Furqan. So why do those statistics occur? There are three main drivers. There's a genetic link, particularly with Down syndrome and chromosome 21. Most of you today will know that people with Down syndrome have an extra chromosome 21. And there's a part called the amyloid precursor gene, the APP, and that is actually located on chromosome 21. When it breaks down into smaller fragments, you get amyloid, and some of you may have heard of amyloid plaques, which build up, and we believe that they are the main characteristics of Alzheimer's disease. Now, the thought is that people with Down syndrome, with having this extra chromosome, may mean they have increased amyloid, giving them extra difficulty in trying to not have dementia. It's not something that's curable. You can't make it go away. There are medications and treatments, but once that amyloid starts to build up, it's very difficult to slow it down other than with some medications, which you need to use fairly early on. And our research looked at this as well. And what we found, of the 15 people that we looked at, and they were suspected of having a diagnosis of dementia or had a diagnosis, 13 of those people had Down syndrome. Now, it's not all doom and gloom. Alzheimer's research is funding specifically around this issue, and they are funding within the University College of London. There's a Dr. Wiseman, and they are leading on the research on the rapid build-up of amyloid within people with Down syndrome. And then Dr. Livesey at the University of Cambridge is using stem cells techniques to grow nerve cells from skin cells of people with Down syndrome. Now, I should say, and we have been asked, the people who gave their skin cells were alive and they did give their permission. But what they're finding is that when they use this stem cell techniques, that they are actually able to increase the growth of amyloid. The next issue that we have, which is another driver, is the cognitive impairments and comorbidities. People with a learning disability often have a really complex clinical picture. Within their learning disability, they may have other health conditions which may or may not be associated with that particular disability. And that means the changes can be really subtle. It might only be family or staff who see them, and that's because they're acting out of character. But within the general population and the way we use testing, it's really not obvious. And often, because it's under the age of 65, we attribute it to something else. And that feeds into the mass symptoms and the diagnostic delay. Standard cognitive assessments rely on communication and comprehension levels, and they may not be within the person's supported own toolbox. People who are non-verbal or who have autistic traits, the challenges are even greater. If you struggle with going into unfamiliar places with unfamiliar people, you're not going to do well, whatever is happening in that room. Never mind, are you looking at a dementia test? The other element of that is if you can't communicate and you have a comprehension that doesn't necessarily look at the world the way the general population may look at, and you're asked to draw a clock. And again, many of you may know that's a very standard test for dementia, draw a clock. And how they draw it makes we're able to see how that dementia is presenting. If you can't draw, you can't draw a clock. It is really that simple. So the tools are just not there. So if you look at the biological factors, the clinical complexity and the tools available, all of these compound the difficulties faced by learning disabled people when dementia is suspected by people who know them really well. Next slide, please, Furqan. So a quick quiz. By all means, put it in the chat. I haven't got the chat open because it's going to be too distracting for me, but do put it in the chat or just have a think about. But at what age should people with Down syndrome begin annual cognitive baseline assessments? Is it A, aged 50, B, aged 30, C, aged 40, D, only when the symptoms appear? And the answer is B. Our NICE guidelines recommend that from the age of 30, people with Down syndrome have an annual cognitive baseline assessment. Now, that's marvellous. But sometimes the NHS, depending on where you live, depending on what that looks like within that trust, and as you know, there are all changes within the NHS currently, you may not know that they are due that test. The NHS may not send out a standardised letter that I do for other testing that they do within the general population. It is very much down to the providers to make sure those happen and continue to happen. And it's very much down to the providers to make sure that the people are answering in a way that's understood by the test. It's a big ask. It's really a big ask. Next slide, please, Furqan. Diagnosing dementia in people with learning disabilities isn't easy. I've already spoken about how the standard cognitive assessments rely on communication and comprehensions that may not be available. There is some Japanese research that showed people with a learning disability who did not have Down syndrome may develop dementia earlier and at a higher rate than the general population. It's happening in Japan, it's happening elsewhere. Because I've already said earlier about the diagnostic overshadowing, that it really is a thing. If you are female and under the age of 65 and you start to look at different ways that dementia might be happening, even within the general population, they're going to say it's the menopause. It might be a bereavement. It might be too many staff changes. It might be parental death, best friend gone. Those things make it look like something other than dementia. So they get missed or they get dismissed by health professionals, not intentionally, but it does happen. This shocked me as well. This misconception that up to 80% of the public and 65% of professionals believe dementia is a normal part of aging. That delays the recognition. Now, over the age of 65, the average time for diagnosis is 2.2 years. Under the age of 65, it's 4.4. Dementia isn't inevitable. Although it is really high risk in people with Down syndrome, it doesn't affect everyone. And that is key, I think. It does not affect everyone. But there is an invisibility of people with a learning disability. If we can't get the baseline assessment right, all the subsequent assessments will not be right because things will be missed. We need to have professionals and tools who can really get to grips with the other aspects that we see within those small changes that are not reflected within the diagnostic tools. Next slide, please, Furqan. There are huge barriers to diagnosis with people with a learning disability. The Down Syndrome Association, Dr. Karen Dodds, has done some amazing work around integrated pathways and put a flowchart and pathway out. This has not as yet been taken on by the local authorities or by the NHS. Each local authority do their own thing. Some of you will know from your own working life or your own personal lives that the NHS used to have a dementia diagnosis target rate. They've taken that away. And we all know that if you're not being monitored or measured, it falls down your list of priorities. So it's not to say these diagnoses are not happening, but the targets have been taken away. As I've said, there's longer diagnosis time. And under the age of 65, there isn't any NHS coding or dedicated funding or targeted services from the NHS. This means over the age of 65, if you get dementia, you will be coded against your height, your weight, your genetics, where you come from, the area you live in, your lifestyle. Under the age of 65, there is nothing. So we actually don't know, and there is no data available to tell us out a percentage-wise of out of people under the age of 65 with dementia, how many of those people have a learning disability. Other than people with Down syndrome, there is no routine screening in under the age of 65 for people with dementia. That's in the general population and in learning disabilities. And this leaves us with no way of navigating through. We rely very heavily on our excellent staff and their excellent support systems, whatever they may be, whether that be guardians, power of attorney, family, whatever that is, we rely on them to push through with us. We really do need clear national guidance and commissioning frameworks that recognise people with a learning disability are ageing. It's really important. Whoever put their thumb up, thank you very much. Next slide, please, Furqan. So more statistics for you. What our research found was the early warning signs were subtle. It was in their everyday tasks. We know the people we support really well. Their families know them really well. And Furqan's going to take you through some of the recognised factors that show dementia and some that we found and were reported to us from many sources. The Down syndrome prevalence really is exceptionally high, and data invisibility. If we're not recording that people have both a learning disability and a dementia, we can't track that. We can't make changes for those people fast enough. If we can't get them through the barrier to be diagnosed, it leaves our staff, our families, our friends who support people really stuck with how best to do things for people. Without the consistent data, we can't adequately fund for future demand. Next slide, please. So this is Mark, and I spoke to his mum earlier this year. Mark was living in one of our residential homes, and for the keen listeners in you, you'll hear that word was. He's a 56-year-old man with Down syndrome who lived in his family home for many years, and he moved into Walsingham and lived in one of our residential homes for 3 years. It was the family and the support staff who started to notice differences. You can see by Mark's smile that he loved people. He loved being around people. He had very few words to speak, but he could certainly make his needs known, and he really enjoyed life. And it started with visual spatial difficulties. He was stepping over parking lines. He was doing steps that were not there. Shadows were confusing to him. Alongside that, he had recurrent chest and urinary tract infections, and he was admitted into hospital repeatedly as his health declined. Remember earlier when I said we have these masking symptoms? So the NHS, people around him, the health professionals, presumed he wasn't feeling well. He became incontinent. He started to refuse medication. He was withdrawn, and on some days he just refused to get out of bed. And that was not the Mark that we knew. And these signs were subtle, and they took months. This started in April last year, and it was a steady, slow progression down. Next slide, please, Furqan. Mark's parents and the staff really pushed for some sort of diagnosis as Mark continued to withdraw. They looked at dementia. They looked at other issues. They didn't immediately pin it all on dementia. But due to his communication difficulties, Mark was unable to explain how he was feeling or describe what was wrong. He couldn't tell you that he thought a shadow was a step or a big hole or whatever it was he was seeing that he was stepping over. His mum broke my heart when she said she felt he was treated differently by the NHS because of his learning disability. And even reading that brings me out in goosebumps. It breaks my heart. Inevitably, there was an MDT meeting, and Mark was found to need nursing care, and he moved into a nursing home for older people. And I spoke to his mum recently, and she told me that Mark still doesn't have a diagnosis to explain all these changes in his health and well-being. I'm sorry that's not a happy ever after case study, but it is very real. I'm now going to hand you over to Furqan, who will take you through the next part of the presentation and the risk factors.
Thank you, Lynn. In this part of the presentation, we're going to look at risk factors and what the evidence tells us about the factors that contribute to the development of dementia, and critically, what that means for people with learning disabilities. The 2024 Lancet Commission report is one of the most comprehensive and up-to-date review of dementia risk globally, and it's identified 14 modifiable risk factors that together account for nearly half of all dementia cases worldwide. And that is significant. What it tells us is that dementia is not inevitable. Prevention and early intervention matter, but as we'll see over the coming slides, the picture for people with learning disabilities is far more nuanced, and the same risk factors don't always apply in the same way as the general population. This slide presents the 14 risk factors identified in the Lancet Commission report. And the key factors span the full life course, from early life through to midlife health behaviors, including smoking, alcohol, physical inactivity, obesity, hypertension, and diabetes. And this is all the way through to later life factors as well, such as depression, social isolation, air pollution, and traumatic brain injury. And what's really striking about these factors on this list is how many of these factors are genuinely modifiable with the right support and right environment. And I think this is probably one of the most important slides in today's presentation. What you are looking at is data from Walsingham's internal research. The graph on the right displays Walsingham's mapping of people's lifestyle and health factors prior to diagnosis against the risk factors identified by the Lancet Commission report. And what we found was 0% reported smoking, only 13% consumed alcohol, 66% maintained a healthy diet, 53% were physically active, 86% were socially active, and only 6% each had diabetes, hypertension, or hearing loss. So on the face of it, this is a remarkably healthy looking profile, and yet these individuals still developed dementia. So what does this tell us? Well, our key findings is that within the learning disability population, and within our small to moderate sample size, lifestyle and health-related factors do not appear to have played a major role in the development of dementia. Our research strongly suggests that other factors, such as genetical influences, and in particular the overrepresentation of people with Down syndrome and its direct link to amyloid production, are the primary drivers of dementia and early onset in the learning disability population. And I want to be clear here, this is not to say that we should not be promoting healthy lifestyles. Healthy living absolutely matters for quality of life, for well-being, and also other health outcomes. But what it does mean is that our prevention and early identification strategies must be calibrated to the specific biology and neurology of this population. What we simply cannot do is apply a general population dementia prevention model and expect the same results. This slide draws directly from the American National Alzheimer's and Dementia Resource Center. And what you can see here is a list of signs and symptoms that are specific to people with Down syndrome who have dementia. And some of these signs might look like behavioral presentations, which we already see in people we support, including difficulty making decisions and sleep disturbance. And I think the risk here is that we attribute these to the learning disability itself, rather than recognizing them as potential early indicators of dementia. And this is called diagnostic overshadowing, and Lynn spoke about this earlier in the presentation. And diagnostic overshadowing is actually one of the most common reasons why dementia is identified late within this population. And my second point on this slide is I just want you to have a look at the range here, from memory and orientation issues, like getting lost in familiar environments or forgetting names, through to physical signs like increased falls, choking incidents, and late onset seizures. What this tells us is that identifying dementia in people with Down syndrome requires a whole person and holistic approach. Let's now move on to section 3 of today's presentation, where we'll be talking about aging in place. In the next slide, we'll be looking at what the evidence says about supporting people with learning disabilities and dementia to remain in familiar and supported environments. This slide presents 4 evidence-based arguments for aging in place, and I want to go through each one carefully, because together they build a compelling case for a different approach to commissioning and care planning. My first point is that supported living already enables aging in place, and it's backed by our freedom of information data across England and Wales. The data shows that transitions from supported living and residential services to specialist dementia or elderly people care is relatively low in volume. And that's not because people don't have dementia. We know they do. It's because in many cases, services are already adapting and supporting people through their dementia journey. And this is already happening. What we need to do is recognize this at scale. My second argument for aging in place is what familiarity means for people with learning disabilities and dementia. Long-standing relationships with support workers, with key workers, with familiar routines, they're not just nice to have, they're actual cognitive anchors. And research shows that when you remove them, there's a rapid decline in well-being, loss of identity, and also heightened distress. And in many instances, we found that the move itself becomes a driver for deterioration. My third point is that gradual adaptation is far more effective than crisis-driven moves. If we are able to proactively plan, adjust environments, and upskill staff, as well as review care plans as dementia progresses, we can often avoid the need for a reactive and distressing move of someone at a point of crisis. And my final point, and my final case for aging in place, is moving people into an older person care setting does not reduce clinical complexity. Often, people with a dual diagnosis of learning disability and also dementia require intensive specialist support even after a move. And that's because the new setting won't necessarily be familiar with their communication needs, their histories, or their behaviours. I'm now going to hand back to Lynn to walk through the key takeaways of today's session. Thank you.
Thanks, Furqan. So, key takeaways. Can we move to the next slide, please? So, it sounds grim. There are things being done, but there's more things that we can do. So your key takeaways from this I'd like you to take is people with a learning disability face dramatically higher risk of dementia, often before the age of 65. The early warning signs are routinely missed due to diagnostic overshadowing and inadequate clinical frameworks. The evidence strongly supports ageing in face, familiar environments, relationships and routines. And data invisibility is a critical system failure. We can't plan for what we do not record or we do not know. Next slide, please, Furqan. So what can you do? You can prioritise early and baseline assessments. You can really push to make sure those happen. If you've got anybody else in your services who you think would benefit from that, push for those to happen on a yearly basis, specifically for dementia. You can undertake medication reviews by applying the STOMP principles to prevent inappropriate use of the psychotropic medication, which might be in place when the assessment's taking place. That can, again, mask what is going on. You can advocate for reasonable adjustments. Some of you may know that the reasonable adjustments flag is now in place in England only, not in Wales or Scotland. And it's up to your GP to put onto their record, as to what reasonable adjustments they need. But you can ask to see that, and you can make sure that it's right for that person. I'd like to monitor equity of access, ensuring that people are not disadvantaged by age thresholds, diagnostic overshadowing, or inconsistent local pathways. Ask your learning disability nurse, what is the local pathway? It'd be really interesting to see if they have one in place. One of the other key things that came out is flexible social engagement with families and familiar faces and locations. Keep those things going. As people withdraw, it's really important to have those anchors in a familiar world for them. Next slide, please. Next slide. We're not doing that one. Apologies, we haven't got time. We talk too much. And so these are pictures from Walsingham and just the great people we support, and just a reminder of why we're here. This is what we do. This is why we all do what we do. Thanks very much.